Yes. I actually told my partners the title of the talk, and they laughed initially. So thank you for having me. I'm Diana Diesen. I must disclose initially that I'm a pediatric surgeon, so you'll hear a little pediatric literature here at the end, and I'm going to discuss an 8-hour appendectomy. So, can we go back? Back? One more. Okay. Sorry. Mouse has a mind of its own. Just back to the first slide. Okay. So I have no disclosures. So appendicitis is a is this working better?
Maybe try that one, because I found that too. So.
There we go. Sorry, I have nothing to disclose. Appendicitis is very common. It's one of the most common emergent procedures performed by general and pediatric surgeons in the U.S. In the U.S., lifetime incidence of appendicitis is approximately 7%, with over 350,000 cases performed annually, accounting for over 2% of all operative procedures. The cost to the healthcare system is not insubstantial. It's greater than 1 million hospital days per year, with an estimated cost of approximately $7 billion. Now, while other procedures are routinely performed as outpatient surgery, laparoscopic cholecystectomies, hernia repairs, for example, surgeons have been hesitant to perform emergent surgery and discharge the patients on the same day. Though this was initially described in 1995, there were a few studies over the subsequent 10 years, and in the past 5 to 6 years, there's actually been quite a lot of papers discussing same-day discharge for appendicitis. Now, these studies are somewhat limited. There's a variable definition of what an outpatient procedure is. Is it less than 24 hours from presentation? Is it less than 12? Is it patients discharged from an observation unit? Is it patients discharged from PACU? There's also a lack of formal patient selection protocols in many of these studies. And there's also, in some of them, a lack of controls necessary to definitively say whether or not early discharge is safe in regards to morbidity or returns to the emergency room. So the traditional pathway for appendicitis is that patients come to the emergency room, they're admitted, they then come to pre-op, go to the OR, go to PACU, go to the floor, and then are discharged from there. In a fast-track pathway, the patient presents to the emergency room, comes to a preoperative observation pre-op area, goes to the OR, goes to PACU, and goes home. And so the summary of the talk is that with appropriate patient education and team education, you can conduct the fast-track pathway in most patients without increase in complications, without increases in ER visits, without increase in urgent office visits, with an average savings of somewhere between $300 per patient and $4,000 per patient. So let's look at some of the data that demonstrates this. So the Canadian group compared outpatient appendectomies to historical controls. Now, they instituted a formal protocol and then looked at their results afterwards, comparing them to their previous historic controls. And they found that 45% of their patients were able to be discharged from the PACU with an average length of stay of 4.7 hours. And if you looked at the eligible patients, so the patients that fit their inclusion-exclusion criteria, 72 out of 85, so 85% of eligible patients were able to be discharged from the PACU. Now, what did they use as their criteria? So inclusion criteria, they said patients had a laparoscopic appendectomy who were between the ages of 16 and 65, had an adult that was able to monitor them for 24 hours and lived within 30 minutes of the hospital and deemed reliable for follow-up. If they were pregnant, they were excluded. If they had insulin-dependent diabetes, they were excluded. Immunosuppression, they were excluded. In the operating room, if they found complicated appendicitis, they were excluded. So we're talking about non-perforated appendicitis here. If they had to be converted, if they were unstable, unable to tolerate oral intake, unable to void, or their pain wasn't controlled, they were excluded. Now, these are their patients. They had 161 initially, 20 for whatever reason weren't offered the protocol, 32 were excluded for those criteria that I mentioned. They either had an open appendectomy, they were too young, too old, didn't have a responsible adult at home, or had diabetes. So then there were 109 patients, 23 of them had complicated appendicitis, so that leaves us with the 85. Of those 85, 72 were discharged early from recovery, and 13 were admitted, 5 for fever, 4 for conversion, 2 for pain, and 2 other. Overall, their outcomes, When comparing to their historical controls, they had slightly more laparoscopic appendectomies than their historical controls. And the only other thing that was different was their postoperative length of stay. The only complication that they noticed that was different was their historical controls actually had more wound infections than their study cohort, but there were no other differences in their complication rate. So the Texas group in 2013 published their results. They had been looking at this for quite a long time, and they looked at their patients from July of 2010 to December of 2012, and they excluded all patients that had perforated or necrotizing appendicitis, pregnant patients, and patients under 18. All other patients were included in the protocol and were extensively counseled preoperatively on the plans to discharge from PACU. I can't emphasize the importance of this enough, especially with pediatric patients. If patients expect to go home from recovery, they're much more likely to do so. They also had a generic caveat that any patient with comorbidities that precluded their being discharged from PACU were admitted as deemed clinically necessary, and this was at the discretion of the surgeon. And so their criteria for discharge from PACU is clearly outlined. They must be able to tolerate liquids, they must ambulate, pains controlled, hemodynamically stable, good respiratory effort, no changes in mental status. They must be able to void. This is the difference in the adult literature. Most of the adult papers require that patients void before discharge. Very few of the peds papers require this. Nausea and vomiting must be under control, and they must have appropriate supervision. And they had 305 patients, and of their eligible patients, 88 were discharged from PACU. Now, this is up from 35% of their patients who were discharged from PACU before instituting this protocol. The average length of stay in the PACU was 2.8 hours, and the reasons for admission included comorbidities, operative or postoperative morbidities. So, for example, enterotomy, serosal tears, they ended up admitting those to watch them, and lack of transportation. So their overall morbidity, counting operative and postoperative, was 6.6%. And some of those were operative, like I mentioned, enterotomy, serosal tear. Some of them were postoperative, so a COPD exacerbation, urinary retention, and 1 DVT. Their readmission rate was approximately 1%, which is what you'll see throughout the literature. In the fast track and in the overnight stay group is readmission rates of approximately 1% for non-perforated appendicitis. So Mitchell et al. Also looked at their patients, and this is a Kaiser group, and they looked at their group from 2008 to 2013. And they had 28 surgeons, so actually quite a large group. There was no clear protocol. This was just a retrospective review of their patient population. And found that 99% of those patients that were discharged from the recovery room were those with laparoscopic appendectomies. And so if you look at the table first, you'll see that early in 2008, only 12% of the patients were being discharged from PACU. But by 2013, up to 60% of these patients were being discharged from PACU. Now, 18% of their surgeons accounted for 63% of the early discharges. So same thing we talked about in some of these enhanced recovery pathways. You'll have buy-in from some people more than others. But of their 2,000 appendectomies shown on the screen, 870, so 43%, were discharged from PACU with an average length of stay postoperatively of 2 hours and 42 minutes. Now, of those 800 and some patients, 9 were readmitted for appendectomy-related problems. And those are listed here. So ileus, abdominal pain, partial small bowel obstruction, abscess, wound infection, pneumonia. And all of these were in greater than 1 day, presented with after more than 1 day. Now, the French took this one step further and said, well, let's look back through our patients that had appendectomies and let's create a scoring system so that we can predict which ones are able to be discharged on the same day. And I'll review that scoring system here in a minute. And then they took that scoring system and prospectively applied it to some of their patients and said, let's really try to do appendectomies as an outpatient. So if they come in before 1, that's great, we'll go ahead and do the appendectomy today. If they don't, we'll give them antibiotics, send them home, and schedule them in the outpatient ambulatory OR tomorrow. And now they excluded patients with pelvic surgery, pregnancy, severe comorbidities, sepsis, excess pain, no reliable transportation, lived far away. And they included patients with CT or ultrasound-confirmed appendicitis with a score of 4 or 5. And this is what they had done. They had looked back at their group, and they had found out which factors tended to be associated with early discharge. And they found that if you were thin, so a BMI less than 28, white count less than 15, CRP less than 30, no signs of perforation on your CT scan, and appendix less than 10 millimeters were all in multivariate analysis associated with early discharge. And so you basically get 1 point for each of those, and you want higher points. So the healthier you are, the less sick you are, the more points you get. And so patients with a score of 4 or 5 in their prospective study, or in their retrospective study, had a increased rate of going home the same day, so 45% and 72%. And so they used that as their cutoff for their prospective study, and they said, let's use a score of 4 or 5, and if they have that score, we will offer them this outpatient approach. Now, what they found was patients with a score of 4 or 5 were able to be operative or discharged from PACU approximately 88 to 92% of the time, depending on who they included. Now, whether or not you can really do this in the outpatient setting, it's a little bit hard to say because their ambulatory surgery unit wasn't available 69% of the time, and so it makes it a little bit difficult to make formal conclusions. Now, specifically about the procedure, most of us, I would say, do appendectomies in a similar fashion. Most of us are doing laparoscopic appendectomies now. These studies include patients who had single port, 2-port, 3-port. All of them describe using long-acting local anesthetic in the incisions. Most of them include using ketorolac during the procedure itself and discussions with the anesthesiologist on using short-term anesthesia, not any long-term sedation, with the idea that patients are going home from recovery. What about children? So this is actually one of the areas where pediatric surgery has as many, if not more, papers on this than the adult literature. And so I'll just highlight a couple of the ones that have come out recently. So the Kansas City group did a retrospective review from 2012 to 2013 and looked at their patients who had had same-day discharge versus an overnight stay. And they had 588 patients with non-perforated appendicitis, 128 of which were same-day discharge. Now, they looked at those two groups and found no difference between the readmission rate, complication rate, or unplanned follow-ups visits in the clinic. Now, when they also looked at the timing, when they looked at the beginning of January 2012, very few patients were going home from recovery. By the middle of June 2013, about a third of their patients were going home from a recovery room. So this is just their trends over time. They did find that it correlated with time of day. So if you had your appendectomy performed in the morning or in the afternoon or early evening, your likelihood of going home from the recovery room was quite high. If you had your appendectomy done after 6 p.m., your likelihood of going home from the recovery room was lower. And part of this they attributed to clinical habit, that this is the way they had always done it, and it took a while for the team to adopt this new protocol, and also family reluctance. Approximately 13% were because families said, no, I don't want to go home this late with my child who just had an appendectomy. The Florida group was actually looking at the same thing at the same time Kansas City was, and they actually asked an interesting question. In addition to safety, what is the parent satisfaction with same-day discharge from laparoscopic appendectomy? And so they looked at their group over 1 year, and they found that 80% were discharged the same day, 20% had an overnight stay. This is all for non-perforated appendicitis. And they asked the family the following questions. Immediately after surgery, how did you feel about going home the same day? Happy, nervous, won't do it again. In retrospect, how do you feel now? And this was in a follow-up phone call. Now, 87% were happy with the expeditious discharge, but 13% were nervous. 92% said in retrospect that they would prefer the same-day discharge, while 8 were unsure whether or not it was the best decision, but would not insist on admission if faced with the situation again. There were no major complications. Their rate of wound infection, urgent postoperative visits, and readmission were the same. And lastly, the group from Florida, different group from Florida, did a prospective protocol from 2012 to 2013. They had very defined preoperative and postoperative exclusion. So preoperative inclusion, this is all in pediatrics. You can't have perforated or complicated appendicitis. You can't have appendicitis that was previously treated medically. No complex medical conditions. They excluded patients that were inadvertently admitted to the inpatient unit, patients who had problems with their social situation or late operations. Postoperatively, you couldn't have hemodynamic instability, inability to void, or poor PO intake or poor pain control. And so they had 350 patients. 28 were excluded initially because they were complex. 8 were excluded because of medical conditions. A few were excluded because of inadvertent admission to the inpatient unit. That left them with 303, of which 100 ended up having complicated appendicitis, so gangrenous or necrotic. That left them with 206 patients, 90% of which were able to be discharged from PACU. Now, looking at the 21 that were admitted, 9 were because it was late OR, 3 for pain control, 3 for unable to tolerate PO, 3 for fever, 2 for social indications, and 1 for medical condition. Now, when they looked at their outcomes, they found no difference in operative complications or ER visits. Now, interestingly, though, they did find a difference, they report here an increased complications in the non-fast track pathway. I think that's a little deceptive because that included some perforated appendicitis. We all know perforated appendicitis have increased risk of some of these complications. But they also reported an estimated cost savings of $4,000 per patient with this increased discharge from the hospital. So all of this to say, the 8-hour appendectomy, it is possible. It's all about patient education, team education, and having explicit criteria for who to include and exclude.